our next speaker will be Dr. Thuy. She's a postdoc at the U of M School of Public Health and Health Management and Policy. She's actually working with Dr. David Mendez on Project 2. She joined our group about a year ago and has been doing amazing work. She's a PhD in mathematics from the University of Padua. And she's going to be talking about the estimation of harm of menthol cigarettes in the United States from 1980 to 2018. Thuy, whenever you're ready, please share your screen and begin.
Hi, everyone. My talk today is about an estimation of the harm of menthol cigarettes in the United States from 1980 to 2018. Our study is available online in Tobacco Control. This is a joint work with Dr. David Mendez. So what do we know about menthol cigarettes? Menthol cigarettes were first created in the 1920s and became widespread in the 1950s and 1960s. Menthol in cigarettes creates a cooling sensation in the throat and airways. Therefore, it masks the irritation and harshness of cigarette smoke. Menthol flavoring is likely to encourage youth and young adults to initiate smoking and delay smoking cessation. There has been an ongoing debate on menthol flavored cigarettes. In particular, in 2011, the FDA Tobacco Products Scientific Advisory Committee menthol report indicated that the availability of menthol cigarettes in the market harm public health by increasing the number of smokers with resulting premature deaths and morbidity. In 2013 and again in 2018, the FDA sought public comments, research results, and other information on the impact of menthol cigarettes on smoking initiation, prevalence, and other factors to inform regulatory actions that the FDA might take on mentholated cigarettes. Finally, in April 2021, the FDA announced plans to ban menthol cigarettes and flavored cigars. In this work, to quantify the harm caused by menthol cigarettes, we estimate the excess smoking prevalence, smoking initiation, and mortality in the U.S. from 1980 to 2018 that can be attributed to menthol cigarettes. In order to do that, we used this dynamics of menthol cigarettes model. So this is a well-established simulation model of smoking prevalence and health effects. We used it to quantify the impact of menthol cigarettes on the U.S. population during the period from 1980 to 2018. The blue boxes here represent major compartments of the model, tracking the number of never smokers, current menthol and non-menthol smokers, and former smokers over time. The circles correspond to the model's parameters, red for menthol-specific parameters and green for the rest. The orange diamonds indicate the events of individuals becoming adult menthol and adult non-menthol regular smokers. The details of this model can be found in the TIPSAC menthol report. We use data from various published sources to fit our model. For instance, menthol and non-menthol smoking prevalence data was taken from the National Health Interview Surveys. In order to estimate the potential harmful effect of menthol cigarettes, we first developed a simulation scenario using retrospective NHIS data to reproduce the U.S. smoking trends from 1980 to 2018. This scenario is called status quo ante scenario. Then we constructed an alternative scenario over the same period, in which menthol cigarettes were assumed non-existent over 1980 to 2080. This scenario is called counterfactual scenario. Finally, we compared the numbers of smoking-related premature deaths, life years lost, and excess new smokers in the status quo ante and counterfactual scenario to quantify the public health harm attributable to menthol over the 1980 to 2018 period. Moreover, we also examined the individual contributions of changes in initiation and cessation due to menthol to the excess smoking-related deaths, life years lost. To do so, we performed 2 additional simulation runs, in which we set first the initiation and then the cessation rate in the counterfactual scenario to their respective values in the counterfactual ante scenario. As described, we simulated 2 different scenarios. Under the status quo ante scenario, the smoking initiation rate was taken as the average smoking rate among 18 to 24-year-olds in the 1980 to 2018 NHIS. In this scenario, there are menthol and non-menthol smokers. Previous studies have shown that the odds of becoming a regular smoker are higher among menthol experimenters. Therefore, under the counterfactual scenario, when the effect of menthol was removed, the smoking initiation rate would be lower. Here are the results of this study. The open circles represent the NHIS smoking prevalence. Triangles and solid circles represent simulated smoking prevalence in status quo ante and counterfactual scenarios. The shaded region shows the 95% confidence band of the estimated prevalence in the counterfactual scenario. So the figure shows that the estimated smoking prevalence in the status quo ante scenario aligns very closely with the observed NHIS data, with the pseudo R squared equal to 0.98. Over this period, we found that menthol cigarettes were responsible for slowing down the decline in smoking prevalence by 2.6 percentage points. Without menthol cigarettes, the smoking prevalence in the US would have been about 11.1% in 2018 instead of 13.7%. And about 10 million extra smokers, 3 million life years lost, and nearly 400,000 premature deaths were caused by menthol cigarettes. Moreover, smoking-related deaths due to menthol cigarettes, explained by 56% of the decreases in smoking cessation and 44% is of increases in smoking initiation. Cumulative life years lost due to menthol explained by 65% of decreases in smoking cessation and 36% of increases in smoking initiation. So this work shows that menthol cigarettes have caused substantial harm to the population. From 1980 to 2018, these products were responsible for millions of excess smoking initiators and hundreds of thousands of smoking-related deaths. Menthol cigarettes harm stems not from the menthol substance itself, but from the changes in smoking initiation and cessation it produces. This is a population rather than an individual health effect. While menthol cigarettes while menthol smoking has been declining for decades now, and it is at historically low levels. Menthol in other nicotine delivery products could exert the same effects that as in cigarettes, stimulating the use of those products. Here are some limitations in our study. First, the results rely on some key parameters taken from the literature. Therefore, the uncertainty of our results is associated with that of those parameters. As empirical research produces updated information about the sensitive parameters in the model, we will incorporate them in the analysis to update, to reduce the uncertainty in the results. Second, the simulation model assumes population characteristics that may not be an appropriate representation for all situations. For example, homogeneity of compartments, proportionality of effects, and among others. Finally, we model the U.S. general population, and we know that the prevalence of menthol cigarettes use is disproportionately high among African Americans. Therefore, menthol harm is certain also to be disproportionately higher among that group. So this work is supported by this grant number from the National Institutes of Health, National Cancer Institute, and the Food and Drug Administration. We would like to thank the members of the CAsToR Data Core for providing several pieces of the data used in the study. And this concludes my my presentation. Thank you.
Thank you, Thuy. I don't know if we mentioned that you had recorded your presentation, right? So
Yeah. So because so around this time, you know, a lot of background noise, so I decided to record. Also, I have a baby at home, and you know.
It worked really well. So thank you. It was a really great presentation, so clear and
looks like a real one.
Yes, nice work. Yeah, so please, if you have questions for Thuy, please raise your hand or type it into the chat. think one question is pretty obvious. You brought it up at the end that the issue of menthol cigarettes is disproportionately affects African American populations. Are you thinking about doing analysis of projections in African Americans or your team or other subgroups, maybe gender-based analyses to see what might be some gender disparities and so forth? And how might you do that?
Yeah, so this is a great question. Actually, we have done the similar analysis for the African American population, and the paper was submitted maybe a month ago, and it's under review. Yeah.
Can you highlight what you may have seen there?
Yeah, so really the number is shocking.
Shocking.
Yeah.
Good. Yeah. Okay. But I mean, I think so. So it's good to hear that you've done that work and that you're submitting it, and that hopefully it will appear soon, as Director Seller said yesterday. Publish. I think this will be extremely helpful to our committee. I wanted to ask maybe. Well, there was a question about uncertainty in the parameters, and how did you incorporated that into the modeling? So could you comment on that? How is uncertainty managed? And
yeah, so we did some sensitivity analysis for some key parameters. I mean, for some menthol-related parameters, by using the 95 confidence interval available in the literature, and then we perform dozens of different scenarios, and then we can assess how sensitive the parameters that we are interested in. Yeah.
I guess through multiple simulation.
Yeah.
By varying the parameters, that's good.
I have just a follow-up. I mean, just do you have any thoughts about what might be other ways to address this issue of uncertainty of parameters, in addition to maybe doing this type of sensitivity analysis?
Yeah, so I think we need more studies on the the parameters that we need for the model. If the more study on it we have, then the less uncertainty it will be. I think so. Yeah. Yeah. So for example, in the model there are some some key parameters which can be found in only one study. So we have to take a risk somehow.
There was a question by Eugene Wan. It's a question about what you do with the menthol smokers in the counterfactual. For those menthol smokers in the anti-scenario, did you assume them as never smokers or as reduced amount of regular smokers in the counterfactual? How did you make this decision?
Yeah, so we know that menthol encourages people to start smoking and relay smoking cessation. Therefore, in the counterfactual scenario, we consider that if we remove menthol in cigarettes, the initiation rate and the cessation rate would change. Yeah, so then we need to evaluate how much changes if we remove menthol in cigarettes would be reasonable, and then we construct the counterfactual scenario using the updated, adjusted initiation rate and cessation rate.
And a related question, but this is by Jonathan, Dr. here in Michigan. He's wondering, so how do smokers that use menthol differ from those who don't use menthol? Besides their initiation and cessation rates, are there other things that they're different from? Like, I guess in reality, we probably could do comparisons of the individual characteristics of menthol smokers versus non-menthol smokers. I guess Jala's question is about within the model. Do these differ in other ways?
No, in our model, they differ only in initiation rate and cessation rate. They have the same mortality risk. Yeah, according to some study available in the literature, they discovered that there is no difference in mortality risk regarding to menthol and non-menthol smoking. Yeah.
But and now that I guess now you're making further changes because you're modeling African American smokers, right? So I guess you've made further changes in order to get those I guess African American menthol and non-menthol smokers. Could you comment on what things change?
So I think one key problem that I see a significant change is the cessation multiplier. I mean, how likely a menthol smoker is willing to quit compared with a non-menthol smoker. So according to a study published in 2020 in nicotine and tobacco research, they found a significant, a significant difference. So they have different numbers for the general population and also for African American population. So we use their results to to populate our model.